Good evening, everyone. Welcome. My name is Maya McCoy. I am a fourth-year medical student at Loyola, and I'm also the co-executive director of Chicago People's Rights Collaborative. I'm honored to be tonight's moderator. Before we get started, I wanted to take a quick minute to invite everyone to officially join Doctors for America, or DFA. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability. There are 6 different levels to choose from. A DFA member will put the link to join in the chat. Also, as a logistical note, we'll be live streaming to Facebook Live and making a recording, and all materials will be available afterwards if you or your colleagues would like to access them. A few quick ground rules for the session. One, there's no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We'll address your questions during the second half of our session. And you can also look out for comments in the chat. DFA staff will be sharing helpful links throughout the session as we go along. So tonight, these are some of our key takeaways that we hope you leave here with. I won't read through all of them, but in general, we hope that you understand the health effects that incarceration has on patients and people who are impacted by carceral settings. We want you to leave with an understanding of why it's important to use your voice to advocate for this population, and then leave with really tangible skills about how you can advocate for folks. And moving into introductions, onto today's speakers, we're really thrilled to welcome Dr. William Weber, who's an assistant professor of emergency medicine at Rush University in Chicago. He helped found the Medical Justice Alliance, a national organization that trains volunteer physicians to provide expert witness work to advocate for the health of individuals in carceral settings. He serves as a vice chair on ACEP's Public Health and Injury Prevention Committee. He also developed Chart Decoder, an app that translates medical terms to help patients understand their medical records. We also have Dr. Anjali Niyogi, who's an assistant professor of internal medicine and pediatrics at Tulane School of Medicine, adjunct assistant professor at the Tulane School of Public Health, professor in social entrepreneurship at the Phyllis M. Taylor Center, and a medical justice and advocacy fellow through the AMA SHLI. She's a volunteer physician with the Asylum Network with Physicians for Human Rights, co-founder and co-director of the Resident Initiative in Global Health at Tulane, or RIGHT, and she's worked in over a dozen countries focused on medical capacity building and humanitarian aid. Dr. Niyogi is the founding director of the formerly incarcerated Transitions, or FIT, clinic program, whose mission is health equity for people impacted by mass incarceration. And last but not least, Dr. Duran Aldredge currently serves as a primary care physician in a carceral setting in California. He's a founding board member of the Black Organizing Project, a grassroots organization focused on the empowerment and advocacy of Black residents in Oakland, California, and in other adjacent Bay Area communities. Welcome to all of our speakers. And we wanted to kick off the event with a question for everyone, maybe starting with Dr. Weber. What called you to work where you work, and how did you end up in your current role?
So thank you all so much for joining. We're really excited to do this training tonight and hopefully help equip you to advocate for people who are either in your care or just who are behind bars. I think for myself, I really ended up here partly through the COVID pandemic. As we were caring for patients in the ER who were at high risk of dying for COVID, we also realized that there were a lot of patients behind bars who were facing similar circumstances. And as we were able to start advocating for those patients and writing to judges and parole boards, I think we saw that by using our medical knowledge and explaining the medical situation and medical topics to these people who just didn't have the medical training, they were better able to make decisions to help release people. And that's grown into the Medical Justice Alliance and is now more of a permanent operation.
Dr. Niyogi, do you want to go next?
Sure. Yeah, thanks for having me. I really got into working with incarcerated and formerly incarcerated people because of the hospital that I work at. So I work for a contract hospital that's contracted to the Department of Corrections. And so anyone who's in a carceral setting that needs a higher level of care is sent to the hospital that I'm in. So I've been working with patients incarcerated for over 15 years. And one day, a very astute medical student had asked what happens when people get released in terms of medical care. And when I looked up what happens, the answer actually was nothing. People were getting released with a bus ticket and, just told to go kind of figure out what to do. And so really recognize this need of people coming out with medical conditions who've maybe been away from their communities for a prolonged period of time. And how do we get them to have, to get access to medical and health resources back in their communities?
Thank you for that. Dr. Aldridge?
Hi, thank you for having me. I think for me, working with the underserved has always really been a passion for me. And unfortunately, the carceral setting is overrepresentation of underrepresented people. And so knowing that, prison can have, two delineations for healthcare where you can potentially get really poor healthcare or have a really transformative experience. I really wanted to work as a PCP in this setting, helping people to really understand their healthcare, any of their comorbidities, and really be able to go back into community, having that foundation of how to manage their comorbidities and what health really is, and then being able to engage with some degree of medical trust with their primary care providers. And I think that, like I said, in the carceral setting, that can be a setup for either having a really great relationship with their primary care provider based on the trust that you've had here, or it can cause some distrust. So I just wanted to be here and build relationships that would last for patients after their transition.
Thank you all for sharing. I'm gonna hand it off to Dr. Weber to speak a little bit to the impacts of incarceration on health.
Yeah, so many of you are probably aware that incarceration is a social determinant of health, and it really has a disproportionate impact, as Dr. Duran was talking about, on marginalized patients in our country. So just for a kind of a brief overview, there are over 1.8 million people in America who are behind bars, whether that's prisons, whether that's jails, whether it's detention centers. And each of these people who are behind bars have a constitutional right to medical care. So the 8th Amendment of the Constitution guarantees or protects against cruel and unusual punishment. And the Supreme Court has held that if you are behind bars and don't have access to medical care and you're not provided medical care, that constitutes cruel and unusual punishment. So each of these people who are behind bars have the right to medical care. Now, unfortunately, what we see is many times patients don't get appropriate medical care, they don't get enough medical care while they're behind bars. So we see that life expectancy is significantly shorter for patients who are incarcerated, and it's even more powerful effect than smoking on life expectancy. And in general, studies have found that around for every year incarcerated, that your life expectancy drops by about 2 years. And not only does life expectancy drop, but we also have many people who are passing away behind bars. So over the last few years, it's been around over 3,000 deaths per year, just in the Federal Bureau of Prisons. Now, most states have what's called a compassionate release law or medical parole for patients who are either permanently disabled or who are near end of life, either terminally ill or really serious conditions. And yet, despite having those laws, many people are still dying behind bars. So we see a lot of big issues, both with life expectancy and not getting appropriate care, and then also with a lot of people dying behind bars when there are laws that would allow for their release.
Thanks, Dr. Weber. And on that note, wanted to pose a question to the panelists about any stories you might have of patients, who are incarcerated that have experienced issues with receiving appropriate medical care. Maybe we can start with Dr. Aldridge first this time.
I think the biggest thing is the stories of validity, right? For my institution specifically, we're kind of in this transition period, and individuals still have kind of lingering impressions of how prison used to be. And there are still there's still a ways to go, right? Like I said, we're in transition. But when you think about stories of validity, it's about, when patients come in to talk to their provider, it's sometimes difficult for them to feel believed. And so when you talk to patients and you have like basic, simple patient-provider conversations, sometimes you'll notice that patients are quite surprised, right? And sometimes are reluctant to even really tell you what's going on with them, right? At face value, you represent the institution that you're working for, and you're not always necessarily seen as a provider, right? And so I think that most providers in community have the benefit of knowing that you're working on the behalf of the patient, but that's not always the case. The patients will immediately believe that about you when they walk through your door or into your clinic. And so just having having patients, letting them know that they're heard, having those stories of validity, validating their concerns, I think is something that's been hard to get patients to start doing when I initially see them. And I think the other thing that's difficult for some patients is having medically appropriate actions taken when there are actions that are maybe unfavorable to the system, right? And so that's like having a gabapentin given to you, where that medication may be frowned upon in the carceral setting, but it's medically indicated for a patient. And so having providers to kind of sign off to that or to agree to do that may be something that may have a little bit more of an impetus for that patient to have done. So I think that patients often, like I said, have problems with validity, then have that extra lap of having them have medically appropriate things done when it's a little bit more harder for the provider to do. But I think, like I said, we're in transition and those are becoming a little bit.
Yeah, thank you for that. And I'll hand off to Dr. Niyogi to speak a little bit to some of these specific issues as well.
Sure, yeah. So I think just echoing what Dr. Aldridge was saying, I think that we are at a point of transition, I think, in this country with the recognition that people who are incarcerated have greater health disparities. They tend to be sicker in general than the general population, and that their health outcomes are oftentimes poorer than people who are in the general population. And so kind of thinking about, what are some of the causes now, underlying causes, the societal causes of who gets incarcerated and why those health disparities exist are one thing. And then the other issue is just sort of logistics of, what happens when you are incarcerated and how does that system work? I think one of the big key challenges is staffing in prisons. And so if you think about how many people are incarcerated, whether it's your local jail or the prison, it's oftentimes, so one of our biggest prisons has a little over 4,000 people that are there. And so there's towns that have 4,000 people, right? And so you have to think about sort of this population health-based model when you're thinking about providing care in incarcerated settings, and that's not always available. And so the number of medical providers oftentimes are insufficient for the population of people that they're serving, especially populations with such complex medical needs. But then also understaffing with corrections officers and deputies. And oftentimes when you don't have enough security staff, it may interfere with the medical care you get. And so if someone needs to see a medical provider, well, that security staff may be pulled to do something else. And so it may delay some of the medical care that you're getting simply because you don't have enough of those providers. Another thing that is a hindrance is medical copays. And so while, Dr. Weber talked about the Eighth Amendment right to have constitutional health care, there's really not a lot of guidance in terms of what that health care looks like or how that health care is reimbursed. What we do know is that there's a federal law that prevents people who are incarcerated from using Medicaid dollars to pay for their health care. And so the carceral settings have to fit in medical care into their budgets. And one of the things that ends up happening is that people end up having to pay copays for things like sick call. And so when you go in my state, a sick call is $3. If you have 2 complaints simultaneously, it's $3 for each complaint. And so that could be $6, which may not seem like a lot. Maybe, for us in the community, we would say, oh, wow, I get to go see a doctor for $3 or $6. That's really a great deal. But for someone who's incarcerated, who may be making an hourly wage of 4 cents to 40 cents an hour, $3 or $6 is quite a significant amount of money. One of the other challenges, when you go in, so if you and I got sick and we, Dr. Aldridge was talking about establishing relationships, and we all know that relationships with our providers are incredibly important, and that trust between patients and providers is incredibly important. But when you're incarcerated, you see the doctor who's on duty that day, right? And perhaps you disagree with that, or you don't feel that you're heard. If that happened to us in the community, we would find another provider. Unfortunately, when you're incarcerated, you don't have that option. And so even if there's this distrust, or you simply just want another opinion, that option is not available to you when you're incarcerated. There's issues with licensures for providers. Part of this is understaffing. Part of this is, a lot of prisons are intentionally away from rural, from urban settings. And so it's really hard to recruit people to work in these remote places sometimes. And, in my state, for example, 2/3 of the providers who are providing care in our prisons have some sort of a restriction on their medical license. And sometimes that may interfere with the care that people are getting. We always have to think about the ways in which prison healthcare is financed. That's done in a variety of different ways. But many of them are provided, healthcare is provided by for-profit medical systems, and sometimes in for-profit prisons. And so the bottom line sometimes supersedes medical care. And we've been talking a lot, and I use the word jail and prison a lot of times. And so I just wanted to give a little bit of context that people may not be aware of the differences between jails and prisons. And that becomes important, particularly in how we're thinking about care that we're providing for them when they come to our medical facility, whether that's a hospital or, maybe a subspecialty clinic, or when we're sending them back to where they're coming from. So jails oftentimes are people who are sentenced to less than 1 year. And majority of people in jails are actually just awaiting trial. So national average is about 65% of people in jails haven't even been convicted. And so and those jails are under the local jurisdiction. So whether it's your county or your sheriff's office or however that happens. And so it's the city's budget that's paying for what's happening within that jail. And one of the reasons it's important to know if your patient's in a jail or a prison is because if you're in a jail, let's say you haven't been sentenced, you're in that 65 to 80% of people who hasn't been sentenced. You go to court, you may get bonded out that day. Those charges may be dropped. You might just walk out that jail that day. And so planning for healthcare, planning for follow-up becomes a little bit more difficult for a jail because you just don't know when you're going to get out. Additionally, because of that system, because there's such a rotation of people coming in and out of the jail, the medical facilities within the jail themselves aren't necessarily robust. Oftentimes they're just set up as a urgent care ER. Maybe there's 1 or 2 people that are staffing it depending on the size of the jail. Prisons, on the other hand, which are either run by state or federal, it's people who are sentenced for greater than 1 year. And oftentimes they're there for decades. And because they're there for a longer period of time, the healthcare systems within them are more robust. And so like Dr. Aldridge is a primary care provider for his patients that are in the carceral settings, the prison doctors become the primary care providers within those settings. And then we have people who are out on community supervision. So these are people who are out on parole and probation, and they're actually accessing the community clinics that exist. And we'll talk a little bit more about those challenges of reentry and medical care during reentry.
Thanks, Dr. Nyogi. And I just wanted to take a moment to highlight the toolkit that DFA and partners put together regarding advocacy for people who are currently incarcerated. So if you go to the DFA website under resources and impact area resources, you'll be able to see the toolkit here. And we'll also put it in the chat, but if you're interested in sharing it with your colleagues or folks at the institution that you're a part of, there's an easy way to download it and share it widely with your networks. Now we're going to move into talking a little bit more kind of nuts and bolts, how to approach advocacy day to day. And I'll hand it off to Dr. Aldridge to start that discussion.
I'm going to start by talking about medical necessity. And I'll start by saying that medical necessity is this very variable term, right? It's really defined by different states, organizations, and institutions. And it varies between even those institutions. So even after you have this really clear delineation of what that means, it's then further complicated by the way it's interpreted by the provider, right? Or the provider team. And that can sometimes look different about what institutions believe are medical necessities. The National Academy for State Health and Policy has a different definition for medical necessity for every single state. So it's something that's really widely variable. For California, we have our code for the California Welfare and Institutions Code, which actually defines medical necessity as a reasonable and necessary service to protect life, prevent significant illness or significant disability, or to alleviate pain, right? Some institutions will see this and they will actually say that it's the actual, whatever is the medical standard at that time. So whatever the standard of care is per the guiding body for that specific illness, they would say that's the medical necessity. Title 15 is actually another governing body for California. And it outlines minimal standards for incarcerated folks here in California. Personally, for me, when I look at medical necessity, I ask myself 3 questions, and it's usually, is this the standard of care? 1, will this progress my patient's care? And then will not doing this action or doing this action impede the progress of my patient's care? And so there are things as simple as like wedge pillows or DME, which becomes very, very pivotal for patients in the incarcerated setting in ways that will not affect people in the community, right? So you think about conditions inside of a carceral setting where people have beds that are really uncomfortable and people have been here for years who have things like osteoarthritis. And so a wedge pillow becomes a hot commodity for individuals in that type of setting. They may not be necessarily medically necessary at that time, but when you're thinking about a therapeutic rapport and how you're going to interact with this patient over time, especially as a primary care provider, that may be something that's going to help progress your patient's care, right? Okay, you have this wedge pillow. Let's think about the next steps. Is this going to get you to go to physical therapy afterwards? Or can we think about alternative ways of treating your pain coming up? And so there is this fine line. There's a balance that you have to think about when you're doing this. And I think that if you can, from my perspective, take whatever the standard of care is, even if it may be different than what your institution outlines as the standard of care, but you can reference that information and put it in your notes. I think that care can be progressed pretty well for patients. And that's what I usually help them. So when we're thinking about restraints for patients, this is also really guided by Title 15 for California. And this also changes by institution, and it changes from jail to county, to state, to federal. And so there are many guidelines, and it also changes by where the setting is within the institution. If you're in the inpatient setting, or if you're in the outpatient setting. When you think about safety, as far as Title 15 is concerned, I think the first thing that needs to be understood for patients in the carceral setting is there really needs to be regular observation of the patient to ensure restraints are properly employed and that it's safe for that patient. I think for me, the biggest delineation that it was a shift of mind for me, is just really realizing that there's a clear delineation between what's medically required and what's custody required, right? We already have patients who are in a carceral setting and are captive already, but that doesn't mean that they lose their rights, right? They retain rights. And so making sure that if I as a provider order restraints, that the restraints that I'm ordering are for a specific medical purpose and not for a punitive region or an action for custody is a very important thing, I think, for medical providers. And so I asked myself, are restraints absolutely necessary? Can there be a less restrictive thing to be employed before using restraints? A lot of times I work on the inpatient side of the psychiatry unit. Most of those patients are usually in a single cell, right? And so if they don't really have any direct impact to another patient or themselves, usually it's not really necessary for you to use restraints. And I can tell you in my time here working at here in California, I've only used restraints once, and it was for a patient who was very, very terminally sick. And then the other thing is that restraints are not finite, right? Title 15 actually states that you can only use restraints for about 8 hours. And if you don't suspect that the patient is going to recover from whatever their medical necessity is for the restraints, then they need to be transferred to another facility. And so it's really important to make sure that 1, there's a medical indication, 2, it's safe for the patient, 3, it's less restrictive, and then 4, that whatever the cause for that initial medical indication for restraints is being addressed and can be addressed. And if not, they're being sent to the appropriate level of care.
Thank you so much. And now, Dr. Neo, you will speak a little bit to best practices for reentry.
Yeah, I'm going to talk about, sort of discharge and follow-up, and I'm going to break it up a little bit because there's probably a lot of people that are listening that may be providing care to people that are incarcerated within their own hospital settings. And so people who are seeing people through the ER or hospitalized patients. And so I'm going to focus on that first, and then we're going to talk about people transitioning out of carceral settings back into the community and things to think about. So if you're thinking about someone who is currently incarcerated, I think that some of the things, just like Dr. Aldridge said, the rights, people retain their rights. And one of the strongest forms of advocacy I think we can do is to ensure that people are getting the same standards of care that they would get in the community, or community members who are hospitalized would get that incarcerated people would. And so when I have people coming into my hospital setting, the ways in which I sort of think about how can I make this as equitable as possible. One of the first things is interacting with law enforcement officials, right? So in medicine, we think a lot about privacy. We think a lot about HIPAA. And when we have people who are incarcerated, law enforcement officials are oftentimes standing right there by the bedside. And so is that really equitable with what happens in the community settings, right? And so finding ways to have law enforcement officials step outside the room. And so while I understand it's important to have our safety and the safety of the patients is incredibly important. And so figuring out, how can you still maintain a line of vision to me, but I get to have the privacy. It does a lot of things. That privacy is important, one, because it establishes that therapeutic relationship, right? It shows patients that we respect them and their medical care, and that we're prioritizing them as patients and not as people who are incarcerated. Right. The other thing to think about too is oftentimes those correctional officers are coming from the same communities that the incarcerated patients are. And so this information, even though they may be trained in HIPAA, oftentimes it may not work that way. They may go back, that information may get transmitted back to people at the jail, and that could have pretty severe consequences for patients, or it could get back into the community. Right. And so really being very thoughtful and intentional about asking law enforcement officials to step out of the room. I think, one of the other ways that this shows up sometimes is who's making informed consent. I think there's a lot of confusion around that. And so really thinking about our patients, just like everybody else, have the right to making their own medical decisions if they have the capacity to do so. And if they don't have the capacity to do so, really ensuring that we have systems in place to make sure that we have medical power of attorneys, and working with your hospital and the prisons to make sure that we are not relying on custody staff to make decisions, and that those processes are in place. When we're thinking about discharging people, so if you're thinking about discharging someone from an inpatient setting, let's say this is where sort of knowing the jail versus the prison becomes a little bit important. If you're sending back to, if we're sending people back to a prison setting where they're going to be there for a longer period of time, it's important to think about how can we educate our patients as best as we can. So we do this for all of our patients who are not incarcerated, right? We review what happened while they were incarcerated. We review their medications. We review all of those things. Oftentimes when people get released from the hospital, they're sent home with after a visit summaries that describe sort of what happened. Now, we're not allowed to necessarily hand that paperwork to people who are incarcerated when they're going back to their facilities. It could be considered contraband, but we certainly can review all of that information, right? And we should be reviewing all of that information. We should let them know you're starting 3 new medications that you need to take twice a day, so that when they go back and they see their provider at the prison, they can ensure that they're getting those medications, or the prison provider can sort out what needs to happen, what's equivalent. Same as we would do when we talk about transitions of care from a hospital back into the community setting. We oftentimes encourage our providers or students to communicate with the primary care provider in the community, right? Your patient just got discharged from the hospital. Here's some outstanding tests. Here's some follow-ups that we really want them to have. And when we communicate that with the community provider, we could do the exact same thing. The Dr. Aldridges of the prison system, right? Those are their primary care providers. And so we should get into the habit of communicating with them. Here's some important outstanding studies. Here's some follow-ups that are recommended. When we're thinking about people going back into a jail setting, remember the people who are going back into a jail setting may get released from the jail at any given time. And so having those follow-ups and having those conversations and those medication recommendations may not come to fruition for someone who's going back to a jail. And so oftentimes if people are getting released to a jail, it may be worth it to put in a paper script into the release packet that can then just be transferred to the jail, and then the jail can send it to them when they're getting released. Same with any follow-up recommendations that we have. It's important to know that oftentimes we talked about copays, we talked about medications that we need to pay for along with those copays. And so even though we may think we're sending somebody back to the prison and, they can just, get Tylenol or ibuprofen or something, but when we write it as a prescription or as a recommendation, then those charges may be a little bit different for when they go in. And then one thing, if someone's getting sent out of your hospital, people go back, transportation gets arranged, and sometimes people are driving in the evening, sometimes at night, early in the morning. And so really thinking about what that process is. Sometimes it takes them 3 hours to get back. They may have missed mealtime. They may have missed, pill call. And so really making sure that we're thinking about those things, give them dinner before they go, make sure that they've gotten their evening medications, because there's a good chance if they get there late, they're going to miss their evening medications. So that's really, releasing or discharging someone from a healthcare facility back to a carceral facility. And then we have to think about, these transitions of what happens when people are getting released from a carceral setting back into the community. And so that's really where, the FIT clinic, the Former Incarcerated Transitions Clinic in New Orleans is kind of where we started, because we saw these huge gaps. We know that there's big health disparities. We know that people are coming out of prison sittings oftentimes with more chronic communicable substance use, mental health, all of these illnesses that seem to be more profound in people that are incarcerated. And then they get released And they're sort of told, well, go figure it out, go find a doctor, you know. And so people oftentimes are released without medications. Sometimes they're released with prescriptions. And depending on those, you know, we talked about many physicians who may have restricted licenses. If they have particular license restrictions, their prescriptions may not be valid on the outside. And so they may not be able to fulfill those. Medical records, you know, many prisons and jails are still using paper charts, or they're using electronic health records that are not compatible or not linked up to community health records. And so whatever happens within that prison or jail isn't always communicated to what's happening on the outside. And so really that transition of care from prison to community is incredibly important, and we should be advocating for there to be a consistent medical process for when people are released out of prison. Other things, you know, people oftentimes are released, they don't have insurance. And so we really have to think about when they're going to find a community provider, can they afford to have, you know, that care, and how can we set up for insurance prior to release? And then, you know, we've talked about incarceration as a social determinant of health independently, and incarceration exacerbates social determinants of health. And so we have all of these collateral consequences as a result of criminal history. And so there's housing restrictions, employment restrictions, licensing restrictions. There's so many other restrictions that prevent people from really getting those, having their reentry be successful because of limitations that exacerbate the social determinants of health, which then worsen their health outcomes.
Thanks, Dr. Nyogi. And now we'll pass it over to Dr. Weber to talk a little bit more about expert witness testimony in MJA.
Yeah, so we've talked a lot about ways you can care for your patients at the bedside, and the toolkit that DFA has come up with has a lot of other practical tips to help support your patients both during and after incarceration. Now, another way we wanted to talk with you about is advocating for patients who are not your patients, specifically who are behind bars. And this kind of brings us to Medical Justice Alliance. So the Medical Justice Alliance was formed out of DFA physicians who were really cared about these people behind bars and were really concerned about the care they were getting. So what Medical Justice Alliance does is simply what you do with your patients every day. Is you take these complex medical concepts and you explain them to patients who maybe don't have medical understanding, just so that they're better able to make decisions about their care. So in the same way, Medical Justice Alliance has volunteer physicians who review medical cases, medical charts of patients, and then explain that to lawyers, to judges who don't have medical training, but want to make informed decisions. So Medical Justice Alliance has physicians around the US. We've worked in the majority of the US states. And we've helped on over 370 cases throughout the US of patients who either are having really poor medical care or difficulty getting supplies, things like that, or who are near death, who have either permanent disability or terminal illness. What we found is when working with, when we're able to work with a lawyer, work with the judge, and help explain the medical care, it gets much, much better. So around 90% of our cases have really positive outcomes for the people who are incarcerated. And what we've seen as well, what we talked about before with compassionate release, the rate of compassionate release is over tripled when you have a physician who can explain, why the metastatic cancer is life limiting, or why this person who's on oxygen in a wheelchair and who's 85 is just not really appropriate for a carceral facility anymore. So if you are interested in helping out, this is a great way to get involved. And what we wanted to do is spend a little time actually providing you those tools to actually get involved and walk you through a practice case. So we're going to take, because we're getting low on time, we're going to go through a practice case. Yeah, you can go in the next one, Maya. So we'll talk a little bit about expert witness testimony. So really what this is, expert witness testimony is just explaining medical concepts to people without medical licenses, particularly judges or parole boards. So this can be either for medical parole, where we talked about, for getting more accommodations, getting a CPAP machine, things like that. We can go to the next slide. So I wanted to take you through a mock case and just so you can kind of demystify what actually will go on if you're interested in volunteering. So we can go to the next slide. We're just going to take a couple of minutes to go through. These are some mock medical records. These are, again, this is a fake patient, but all these medical conditions and issues that come up are based off of real patient stories. So what we're going to do is have you read the medical records for a couple minutes. If you don't have a medical background, if you're an advocate, a lot of these terms might be confusing to you. There's a non-medical version or a less medical version that is in the chat that you can read. But we're going to take just 2 or 3 minutes, read through the medical records and see if there are any concerning findings that pop out to you. Things that maybe if that was your patient, you'd have some issues with, or you might want them to get better care. If you're willing to, post something in the Q&A and we'll talk about it together in a few minutes. So thank you to those of you who have already contributed. Keep adding in while we talk about it. But we'll just start going through this case. So yeah, I think some people have already pointed out, like, there are definitely some concerning features about this case. So Erica had mentioned, this person is an elderly gentleman who fell from the top bunk. Again, maybe someone this age shouldn't be on a top bunk, fell and hit his head, and now he's having kind of abnormal mental status that was unaddressed. Now, and had mentioned he should probably have a CT scan. So yes, like this person definitely has concerning findings with a CT scan. Someone else had mentioned, this person is having worsening headaches and they're just treating it with kind of over-the-counter pain medications, not really looking into it. We had a patient who was in custody and was acting abnormally, and again was getting disciplinary tickets because he was pushing water over and things like that. And they found out later he was in diabetic ketoacidosis. So this gentleman had a blood sugar of around 700, a pH near 7, and that was leading to his abnormal mental status and acting abnormally. We also had another lady who, again, was acting abnormally, was getting disciplinary tickets, was put in solitary confinement for over 10 years until someone finally decided she should be evaluated, and they found she had a brain mass. And once they were able to remove the brain mass, her behavior, her mental status went right back to normal. So many times there are things that are just overlooked. And now, fortunately, there are many good physicians like Dr. Duran who are working in these facilities, but many times there are physicians who are either just overworked or maybe are struggling to work within the system. So us as physicians who can point out some of these issues, for instance, this person has unchecked blood pressure that has been running hypertensive, shortness of breath without really any workup. Like, as we can point these things out to judges, to parole boards, things like that, then they can actually mandate that these things happen and really make sure that patients get good care. So that's the first kind of part. If you're interested in working as a volunteer with Medical Justice Alliance, the first part is usually reviewing medical records. And usually it's 100 to 200 pages, which sounds like a lot, but usually is not as thick or condensed as this, and usually just takes a few hours. The second part is really, once we've understood the medical situation better, is transitioning over to actually communicating with the other people. So on the left here, we see an example. we as physicians are often writing to each other, writing to colleagues about patients. So we use terms like myocardial infarction. And something like that to a physician would make sense, but to a judge who has never gone through medical school, it would not make much sense at all. So another part that we practice typically is how do we distill these records and use the medical terminology, use the medical concepts, but explain it in a way that patients can understand. So Maya, you can actually click ahead. Just an example. An example is here, using terms instead of hyperlipidemia, high cholesterol is a lot more accessible to a judge, to the lawyers, just to help them better understand it. And fortunately, this is a thing that we do every day with our patients. When we are describing and explaining things to patients, we try to simplify the terminology so that we can still be precise, but it's understandable for them. So that's really all there is to volunteering with Medical Justice Alliance. So if you're interested, again, these cases usually take around 4 to 6 hours total, and that's over the course of 4 to 6 weeks. So overall, it's a light lift. We provide mentorship. We can pair you with either if you're a resident or a medical student, we always pair you with an attending physician. And similar, if you're an attending physician, we can always pair you with learners who can help you along the process. So that's an opportunity. Again, working in this space as a volunteer is so critical to patients getting appropriate medical care. You all have expertise in the medical field. And you're really good at picking out issues of care and places where patients maybe aren't getting the care they need. So not only can you help with patients, help their own life expectancy, help them in suffering and in the medical issues they're dealing with, but you can also work to help change systems of care, both through political advocacy and then larger cases where we're looking at systems of care within the hospitals. Because many of these providers who are working in the hospitals are bumping into the same issues that we see, patients who can't get specialty care appointments or who are just not getting the medications because of gaps in care. So by working as a volunteer, you can really help set up these hospitals, we're caring for the patients, and then the facilities to provide them better care.
Thanks, Dr. Weber. So that brings us to the end of our content. We've covered all the way from the systemic issues to some really tangible ways that folks can get involved. And to close out for our panelists, wanted to ask if anyone has any stories of a personal success where your position as a provider made a difference either for a patient or largely more systemically. Anyone can start with that one.
I'm happy to jump in. So for instance, one of the Medical Justice Alliance cases that we had with I think actually a CPRC team. So there was a gentleman who had he was wheelchair bound. He had incontinence. He was in his late 70s and he had end-stage Parkinson's. So he had a difficult time just even feeding himself, toileting, things like that. He had been denied parole 7 times in the past, partly because they didn't understand kind of what was going on with his medical condition. So once we were able to pair him and his lawyer with a physician, they were able to explain what was going on, and he was able to get medical parole. So now he's been able to be at a nursing home where he gets his care, where he has a lot of skilled nursing care who can provide for him. And we actually recently were able to take him to Hamilton in the city. He was so excited to get out and see theater because he had been in prison for over 30 years, and was just so excited to see a play. So little moments like that, you can really make a difference. It's a small time commitment, but it can change someone's life.
Dr. Aldrich, go ahead.
I was just going to say, I would just echo what Dr. Weber says. I think that there are multiple stories of getting somebody medical parole or compassionate release, or even just getting them medical care within the facilities. And so sometimes, even if someone isn't getting released, ensuring that they get the MRI that they need to look for metastatic cancer or any of those other things. And really, one of the things I think we forget is that our education really does make us experts, and even medical students who feel like I'm just starting off in this, we really are experts when we talk about people who are in settings outside of medicine. And so really just explaining, if we looked at that case to say, oh, this person's got dizziness and uncontrolled blood pressure and diabetes, and just really explaining to somebody that, oh, a standard of care practice would be to get a head CT. And so perhaps advocating for that patient that we had earlier in our mock case to get a head CT, as many people had recommended. But it really does make a difference. And there are so many stories of success that I really encourage, the more people that are able to join in to do this kind of work, I think the stories will continue to grow.
I think for me was a patient who had very poorly controlled diabetes for a very long time. And coming into the experience, I really just kind of was looking for barriers to care for this patient. And really for him, it was medical distrust. He had been around the crossroads setting for most of his life, and didn't really trust his providers. And he didn't trust me either. But I think over time, we built a rapport. And I think for the first couple of encounters we had, it was just discussions, thinking about talking about the things that he thought about his diabetes and how he could change it. And then me just trying to give him education about ways that I thought that we can make changes. And for, I think for about 2 weeks, we kind of just did it his way. We did, all right, he kind of told me what he wanted, which was to, kind of just tried some lifestyle modification. And once he figured that I gave him that autonomy, we kind of talk about that in medical school, we talk about ethics, to make his medical decisions, he slowly but surely started being more receptive to some of the things that I offered. And just about a month ago, we got his blood sugar under control with some shared decision making, which is amazing. So I know it's a small victory, but it feels good, So yeah.
Thank you all. And just to wrap up, some tangible next steps. We talked a little bit about how to download the Carceral Health Toolkit, and we can drop that link in the chat again. There's also a link to learn more about MJA and consider volunteering. You practiced doing a little bit of the record review here in today's session, and there are a lot of opportunities also to be mentored through cases and get more training if you're interested in being a volunteer. Definitely share all of this information with your colleagues and coworkers. And then also there's an opportunity to attend the National Leadership Conference, and you can scan the QR code here to learn a little bit more. Okay, we can just wrap up then. So just to close today's event, I want to thank all our panelists for this thought-provoking discussion. I want to encourage the folks who joined to watch for opportunities to join other related presentations, and we're so grateful that you made the time to be here this evening. Before you leave, a couple quick reminders. If you registered to attend, you'll receive a copy of the toolkit and a copy of the presentation slides as a follow-up. And just thank you again for being here, for all that you do on behalf of patients. We hope you'll become an official DFA member and take a look at the benefits of membership on DFA's website. The #1 reason doctors, medical students, and health advocates join DFA is to be at events like this with like-minded people that share similar values and priorities. And you can also get a sense of the work by following DFA on Twitter, LinkedIn, and Facebook, just to stay up to date and get up to date on ways to stay engaged. Thank you all again.